heart failure trials in general, it's very slow and difficult enrollment in the current era. In the current era, the numbers that are frequently quoted are 0.2 to 0.3 patients per site per month as the enrollment rate, so very slow. Our research here was focused on the timing of randomization in a hospitalized heart failure trial, and we looked at the Astronaut trial, which was a trial that was published in JAMA a few years ago, and it was a neutral trial of aliskiren versus placebo in hospitalized heart failure patients. No difference in post-discharge outcomes. So that's the database. Now, the clinical question for us as we're trying to think about trial design and operations is that every hospitalized heart failure phase 3 trial to date has been neutral. So as we try to think about doing like an autopsy of how we can think about designing these trials going forward, one of the things that we've noticed is that these trials near uniformly include a mandatory early enrollment window. So what that means is that the timing of hospital presentation, when that happens, the clock starts for the trial, and the patient needs to get in that trial within a few hours or a few days, or they're no longer eligible. So we have to ask ourselves, is including a narrow early enrollment window as the only opportunity to enroll a patient, is that adding an extra challenge to that enrollment rate? And if we made things more flexible, could we help the enrollment rate? The other thing is not just the enrollment rate, but it's a big burden for sites to have to be able to only enroll patients during that narrow window. They have to rapidly identify someone very early after they come to the emergency room, and they have to get down there, get them through the consent process. And then the other challenge is that it imposes this feeling of being rushed, potentially. And this could have negative implications for the patient. Maybe they're not able to understand the consent form as well as they normally would if they were able to take their time, ask all their questions. And also from the study coordinator perspective, they have to be rushed potentially to get through the consent process, enter all the data. They also might be rushed for making sure that the patient is actually an appropriately eligible patient. And it's theoretically possible that this feeling of being rushed could lead to protocol deviations on the part of the site as they don't have their time to go through the process under a more relaxed timeline. One of the things we wanted to look at in this study was, does that early enrollment window, does it make sense when you assess the pros and cons? And Astronaut was the only recent phase 3 hospitalized heart failure trial that did not include an enrollment window. So thus, it gives us an opportunity to compare patients that were enrolled both early and also very late in the hospital stay and see if there's any differences in those type of patients that get into the same trial. Our hypothesis going into this was that heart failure patients in Astronaut that were enrolled early versus enrolled late would be no different in terms of the characteristics at the time of randomization. So at the time the trial actually starts, they would be very similar. And our other hypothesis was that they'd also be similar in how they did afterwards, how their post-discharge longer-term outcomes were. And we thought that if we were able to show that the patients were similar in how they looked at randomization and were similar in how they acted after randomization, that this could potentially give us lessons for future trials on the utility of including an early enrollment window. In general, we confirmed our hypothesis. We saw when we looked at the clinical characteristics at the actual time of randomization, patients were very, very similar in terms of vital signs, labs, comorbidities, very similar. We also saw that they were very similar in how they did after randomization, so their outcomes, both 30 days after randomization and longer at 12 months after randomization, no differences in mortality and hospitalization endpoints. We also saw that, thinking about that operational, is there a price to pay on operations by timing of randomization? We actually saw there was actually no suggestion of a price to pay. There was no association with increased protocol deviations or withdrawal of consent, things like that. That was not associated with timing of randomization. So essentially patients were similar across all elements. These data suggest that a future trial that's looking at hospitalized heart failure patients and looking at post-discharge outcomes, that kind of trial design may benefit from allowing patient enrollment throughout the hospital stay. And that the other characteristics for inclusion-exclusion, like blood pressure, comorbidities, those are the dominant features that shape the risk of the population that's ultimately accrued, not necessarily a mandatory early enrollment rate. So this could have benefits on optimizing the operations, enrollment rate, making things easier on sites in terms of the burden, and you're not necessarily losing anything from a scientific perspective on the patient profile. In DCRI, really we offer services attacking all these angles and can kind of give you a whole picture on not just the therapy and the science of it, but operationally how to design a trial, how to execute a trial, so you get a result that is actually representative of what the therapy actually does.